and reach to a consensus so that we can give a clear message to the viewers. And today we have esteemed chairpersons, Dr. Sonia Malik Madam and Dr. Atul Munshi Sir, and our speaker, none other than respected Dr. Rishma Pai Madam. I would like to formally introduce convener of this series, Dr. Anju Soni Madam, to the House. Dr. Anju Soni Madam is recipient of Best Committee Award for her work in Fox's HIV Committee. She is the director of Sony Group of Hospitals at Jaipur, and she is at present currently president of IMS. We congratulate you, ma'am, on this new post and wish you best in your endeavors. I would like to hand over to Madam for further proceedings for introduction of chairpersons to the House.
Thank you so much, Dr. Reshmi, for your kind introduction. And I'm really honored today to have Dr. Reshma Pai as an orator and Dr. Atul Munshi Sir, a very, very senior veteran of Foxy, and Dr. Sonia Malik, who will be joining in a while, and the coordinators, Dr. Prateek, and you all for always being there. And my dear colleagues who are attending this webinar, it's my honor and privilege to extend a heartfelt welcome to each of you for our exclusive webinar on the revolutionizing fertility outcomes in female genital tuberculosis. Today we gather, a community of dedicated medical professionals united by a common purpose to advance frontiers of women's health and pioneer new pathways to excellence in patient care, led by illustrious Dr. Reshma Pai, President Foxy 2017, along with her experts, Dr. Atul Munshi, Foxy representative of CEFOG in 2016 and 17, and ICOG chairperson in 2014, and Dr. Sonia Malik, Chief Clinical Mentor and Pan Nova IVF Group. This event represents a convergence of brilliance, innovation, and composition. A topic at hand, female genital tuberculosis, is not only a complex, but also profoundly impactful, particularly in its implication for fertility outcomes. As we embark on this journey together, we have a unique opportunity to explore groundbreaking strategies, challenges, conventional paradigms, and ultimately redefine the standards of care in this critical area of medicine. Over to you, Dr. Munshi sir.
Thank you. Ever smiling Dr. Anjali, our new IMS president. For today's speaker, a lady with grace, Dr. Rishma. My friend and well-known infertility specialist will join us soon. And learned coordinators, Dr. Prateek and Dr. Rashmi. Tuberculosis is an age-old disease, especially in India. As far as female pathology is concerned, tuberculosis plays an important role in menstrual irregularities, chronic pelvic pain, and infertility. When we were students about 40 years back, the common cause of female infertility was genital tuberculosis. Then came the era of HIV infection. So Dr. Sonia is joining.
I'm on a webinar. I'll call you later. Okay?
Then came an era of HIV. Again, tuberculosis was commonest associated. And now with resistant strain of tuberculosis bacilli, the disease is resurfacing. We have an expert in the field of infertility to discuss the topic of improving fertility rate in case of genital tuberculosis. Let's hear them. Welcome, Dr. Sonia.
Good afternoon, sir. Good afternoon to everyone. Good afternoon. I'm sorry I'm a little late. Thank you very much, Anju and Prateek, for having me here today. And of course, we have Reshma here, who is an expert at tuberculosis and delivers the most difficult aspects of tuberculosis with great ease and aplomb. So I'm really looking forward to your lecture, Reshma. This is going to be really very, very exciting. Thank you. And thank you, Rashmi, as well.
Over to Dr. Reshma.
Thank you. Good evening to all of you. Thank you, Dr. Anju, for inviting me for this very, very important subject to discuss today. And I'm a little concerned because I have super experts like Dr. Sonia Malik and Dr. Atul Munshi here, and they know and have experienced more about tuberculosis than I have. So I'll be very happy to hear their critical appraisal at the end of it, definitely. Prateek, you're amazing. We know that if Prateek is behind any organization or event, he's going to do it really meticulously. So thank you for that, Dr. Rashmi. Thank you all. I will start my presentation in just a minute, if you allow me to share my screen. All right. Are we good to go? Can I be seen and heard?
Yes, you can see.
Carry on.
Clear,
Thank
clear.
you. Thank you so much. So good evening once again. And today we are here to discuss extremely common yet still confusing, complicated problem, and for which we don't have any simple tests or solutions. And that is the problem of tuberculosis, particularly fertility outcomes in female genital tuberculosis, which again is compared to general tuberculosis, hard to diagnose and treat and improve outcomes. So let me begin by saying that some problems are really so complex that you have to be highly educated, intelligent, and informed just to be undecided about them. And even today, despite so much knowledge and experience, there are a lot of situations and occasions in which we are still undecided about how to go about treating a particular patient and whether she really is even suffering from genital tuberculosis or not. So the incidence of female genital tuberculosis, as you know, varies really depending on which part of the world you're practicing in. It could be as low as 1% in the infertility clinics in USA, and it could be as high as 1 to 19% in certain areas of India. And the incidence also really depends on whether the patient has come to you primarily for infertility or for some other problem. And in patients who come to us for treatment for fertility, the incidence is very, very high, 25% overall almost, and 48.5% in patients with tubal factor infertility. So for patients who are infertile, who require IVF, we see a fairly high incidence of tuberculosis. Just a quick recap, we all know female genital tuberculosis is caused by Mycobacterium tuberculosis, and rarely there could be other types of atypical mycobacteria. And usually there is a hematogenous lymphatic or direct spread from abdominal tuberculosis. And remember that in most cases, tubes are the ones which are affected. So 90% of women, fallopian tubes will be affected, whereas uterine, the endometrium, in 70%, and ovaries, fortunately, are often spared. And only 25% of the females with female genital tuberculosis may have ovarian involvement. Symptoms, as you know, are often absolutely non-specific or not there at all. She may be completely asymptomatic, or she may have some weight loss or mild fever or general poor condition, rarely menstrual irregularities. All varieties of menstrual irregularities or dysfunctions can be there. And very often she presents only with infertility and no other problem. Rarely you can see an abdominal mass if there's a large TO mass, some chronic abdominal pain or pelvic pain, some vaginal discharge. So we may or may not have these symptoms, and which is why it's difficult to diagnose. Even when we examine the patient, we may find some that she's having fever, she has some lymph nodes, she may have pulmonary tuberculosis evidence, which then is easier to pick up with Krebs, etc. on a chest examination. The abdomen may have a doughy kind of a feel, you may have ascites, and when you do a upper vaginal examination, you may sometimes have, adnexal mass, which you can palpate, very rarely in large uterus if there is some pyometra or something like that. But like I said, again, very often you may have no symptoms and no signs, and you have to rely again on tests to diagnose tuberculosis. And you can see the number of tests that are available to us. Unfortunately, none of them are extremely specific or sensitive So you can go through your basic blood count, and of course, a high ESR gives you some kind of a suspicion. Chest X-ray, if she has pulmonary tuberculosis now or in the past, you may be able to pick it up. A MAN2 test is not really reliable because most people in India have been exposed to tuberculosis or the vaccine. Endometrial biopsy, if we actually analyze properly in detail, you may get a very strong suspicion or actually prove the infection. Cultures are again important, and I'll come to that in just a bit. PCR test is very good. It's a rapid.
Ranjit, why recording is stopped?
And have false negative
And
test.
there was an issue. I resolved that. Sorry to.
Gene expert test. So these are some of the new tests that we have. We have gene expert, we have interferon gamma release assays. These are some things which I can just talk about in a little more detail soon. And then, of course, some of the imaging technologies that are available to us. Very rarely, we may need to do a CT scan if they're adnexal masses, or an MRI, basically for adnexal masses if we can't diagnose them well. So the WHO says that you only diagnose extrapulmonary tuberculosis if there is a culture positive specimen or positive histology or strong clinical evidence consistent with active extrapulmonary tuberculosis. So have one of these things positive as per WHO. Because we know that, the general X-ray or even a MAN2 test, etc., are all non-specific and do not give us the information. So we may get a lot of false positive tests because of some kind of a prior exposure. One of the age-old tests which still continues to give us good information if there is significant damage due to tuberculosis is the hysterosalpingography. And you can see very classic pictures. All of us have done this during our, medical school days, picked up and helped to, sort of understand or describe the tubal dilatation, the tubal occlusion, the diverticular outpouching, what we used to call the salpingitis isthmica nodosa. Very often there's a hydrosalpinx, cotton wool plug, golf club tube. So all of these classic descriptions of a tube which is damaged by tuberculosis. Also, if there is partial obstruction of the tubes, there are synechiae around when the spill is happening. Calcified lymph nodes are seen. Calcification in the adnexal area, you can suspect tuberculosis. And even the uterus in certain cases may show classic changes like a collar stud abscess, T-shaped uterus because of partial obstruction due to adhesions, or a pseudo-unicornuate uterus. Sometimes we see a complete narrowing of the uterine cavity called the Netter syndrome. So all of these, depending on the severity of the infection, you may be able to pick up of these. Cervical tuberculosis, of course, is quite rare. And, you may see this very feathery appearance or a cervical distortion if that is also affected. So HSG will give you a fairly, nice picture if there has been significant damage with tuberculosis. The sonography, again, may or may not reveal much information. If the tubes have been affected badly, you may see them thicker, you may see a hydrosalpinx in some cases. If the endometrium, again, may be very, very thin and non-responsive, very poor vascularity in certain cases, you may be able to pick up adhesions if you do a 3-dimensional sonography or push in some fluid, you'll be able to see that. And so, very rarely you find the very specific sonographic evidence of oligemic myometrial cysts, follicles with echogenic rims, and presence of fluid in the endometrial cavity along with hydrosalpinx. So, like I said, sometimes the diagnosis is not obvious at all on sonography. You may have to resort to CT or MRI if there are adnexal masses to diagnose this. Laparoscopy, however, gives us a much better visualization of the actual condition of the uterus tubes and ovaries, and you can actually combine a hysteroscopy, you can take a biopsy, you can take a material for culture, and you can actually pretty much come to a conclusion as to whether this patient has hemogenital tuberculosis or not. So the laparoscopic findings often are pretty classic. You can see sometimes tubercles, fimbral blocks, fimbral phimosis, tubal beading, adhesions, masses, rigid tubes, etc. And so if you see, when you're pushing in the dye, if you can see a lot of intravasation of the methylene blue and the whole uterus becoming blue, you can sometimes, almost diagnose that this is tuberculosis. Very often you may see even a frozen pelvis because of massive adhesions. You can see this on the liver, the presence of adhesions, which again could be indicative. So you may or may not see such a classic picture on laparoscopy, but these are diagnostic. Sometimes you may see much less damage, but typical caseous spots, and that again, you can biopsy them and you can prove that this is tuberculosis. Hysteroscopy, of course, very often you'll see a very pale, thin endometrium. You may see adhesions, and that is quite, suggestive of tuberculosis. And so, you may be able to take a biopsy and send it for examination. So once we can see on histopathology, or we can culture this tissue and see the mycobacterium presence, then we can ascertain 100% that this is tuberculosis. So histopathology, typically we'll see the caseous granulomas with giant epithelioid cells, which is suggestive of tuberculosis. And the important thing is to collect the specimens in right quantity, multiple sites. If you're sampling the endometrium, do that premenstrually, because then you get a lot of material to actually sample. And then you'll see the classic giant cells and tubercles, and you'll be able to diagnose endometrial tuberculosis. Of course, we have the AFB staining, has been there for years. We've learned it in our growing up years, and classic methods, to diagnose mycobacteria tuberculosis, microscopy, culture, do the acid fast staining or fluorescent staining. And you have to have, for all of these, a good amount of bacteria. So for Ziel-Nielsen staining, you have to have a sample which has at least 10 to the 4 or 10 to the 6 bacilli per ml. And even for culture, you need at least 10 to 100 bacilli per ml of that tissue or fluid which you are giving. So depending on the quantity that you pick up, you can actually, determine if there is a tuberculosis or not. Even menstrual blood you can culture, but the sensitivity is pretty poor. And, endometrial curating, for example, if you want to do AFB, you require at least 10 organisms per ml for a positive result. And this is why, even though sometimes we do a biopsy, we do this, we don't get definitive results, because maybe the quantity is not adequate for testing. Culture, like I said, is one of the most important diagnostic tests. You can do a solid culture on the LJ medium, or you can even do a liquid culture. And the advantage of the liquid culture is, of course, the sensitivity is good. You can not only identify the mycobacteria tuberculosis, but you can also perform drug sensitivity. So if there is a sensitivity for rifampicin, you can pick it up at that moment, and you can recommend even the drug to the patient. Important, of course, is that you have to wait for a long period of time. And, the first results come in 7 to 10 days, and then you have to keep on waiting for up to 6 weeks for making sure that the culture is negative, or, if the patient is positive or not. So this is a long delay in diagnosis, and which is why there is focus on the molecular techniques to diagnose tuberculosis. The nucleic acid amplification test, the NAT tests, which give you the results in just a few hours. PCR is something we are using routinely for many different diagnostic, tests, and you can actually pick this up in just a few hours. The problem is that these PCR assays can detect a very small number of bacilli and even dead bacilli. And that is why you get many false positive results, even though these results come in very quickly. So the sensitivity is high, but also the false positives are high, and which is why we have to be very careful about starting antituberculous therapy just on the basis of a positive PCR test, because like I just mentioned, it can pick up even dead bacilli. So there may have been a disease in the past, but patient doesn't have currently the infection, and you may still be treating her. Serologic tests are not to be done, and they have been, the WHO, in fact, has strongly recommended that you do not do any of these tests. So recently, we have some new tests recommended by the WHO. The Gene Expert assay has been endorsed by them, and basically, it can pick up all kinds of extrapulmonary tuberculosis and gives you results very, very quickly. So these tests have come in. Again, I don't think they have a magical diagnostic, 100% sensitivity or specificity, but these are rapid tests. They are fairly accurate compared to the other existing tests. So basically, for Gene Expert, again, we use a semi-automated real-time PCR technology, and it can detect the tuberculosis as well as the sensitivity to the antibiotics. We also now have the interferon gamma release assays, which are whole blood tests, and you can help diagnose female genital tuberculosis. The problem is these tests do not differentiate latent tuberculosis and active tuberculosis disease. And so, again, we are in a confusion as to whether this is just a latent or an active tuberculosis. And two of these tests have been approved by the US FDA. We have the quantiferon TB Gold test, and we have the T-Spot test. And these tests basically, they measure a patient's immune reactivity to mycobacterial tuberculosis. So these tests, are rapid, they're relatively more reliable, but again, different, difficult to predict whether she has an active progressive tuberculosis or a latent form of the disease. So you can see that we've spent a lot of time even coming to a diagnosis of tuberculosis. Once you have a diagnosis, whether on culture or on, microscopic examination or any of the PCR tests, etc., and you have confirmed this, then we start the treatment. So the treatment is pretty standardized, and you can see we have categories of tuberculosis. The category 1 falls in all these new smear positive patients and, patients who have some pre-existing disease like HIV or, severe forms of extrapulmonary, even female genital tuberculosis comes into that. So for this, we can just give 2 months of 4 drugs, INH, rifampicin, ethambutol, and pyrazinamide, and followed it up with 4 months of INH and rifampicin. So this is usually okay for the first category of infection. But if as the categories worsen, as the disease is either you have relapses of the condition, or even if your first line of therapy has not worked, or patient is more resistant to therapy, then you will have to add in maybe streptomycin and, so give 5 drugs for 2 months and then go on to give the other drugs for the next 5 months. And in cases which are resistant, multi-drug resistant, then you have to go on to the next line of therapy. For example, ofloxacin, cycloserine, etc., kanamycin. So this is the next line of drugs. And the therapy can be either directly observed treatment, short course, where you call the patient and you give her the drugs in front of you, or it can be non-directly observed treatment, short courses, whichever is depending on the patient's compliance, etc. Surgical treatment doesn't really have a role to play. In active tuberculosis, it is to be avoided because it can actually flare up the disease and cause a lot of complications as well. And we know that surgery in these cases are required only if there's a large TO mass or an abscess, or there's a pyosalpinx, or in a hydrosalpinx, you have to remove the tubes prior to IVF. Then we would recommend surgery. Also, hysteroscopy sometimes to open up the uterine cavity if it is damaged by adhesions or Asherman syndrome. And of course, make sure that inform the patient that complication risk is high, injury to bowel, because surgical planes are pretty badly damaged in these patients. And so we have to be very careful, but do not try to do tuboplasty on these badly damaged tubes, because then you are normally not successful and the risk of ectopic may really be significantly more. So damaged tubes with tuberculosis, there's no point in trying to open them out and trying to do a tuboplasty on them. The most difficult thing is, I think, the diagnosis or the management of latent tuberculosis. If we have done a PCR test and it comes positive, but there's really nothing else to indicate tuberculosis, should we be treating this patient? And the logic of it is only that if you treat it in an early stage, you'll probably prevent progression and less damage to the organs, and you'll eventually get a good pregnancy outcome in these patients. However, just treating these women who have a positive PCR, then you may overtreat a lot. And the treatment is not simple. It's a long course. The drugs have side effects. And so it's a real dilemma whether we should or should not be treating these patients. And there's a nice study from All India Institute with Dr. Kriplani a few years ago, who actually took 100 women with proven tuberculosis with infertility and who had a positive endometrial aspirate. Their PCR was positive on the endometrial aspirate. Tubes were open and everything else was normal in the patient. And these patients were divided into two groups. Half of them were given the antituberculous therapy, half were not given therapy, and they were observed. And it was found that whether you treated these patients or did not treat them, the pregnancy rates were similar. So this only positive PCR test, even if you don't treat them, they'll become pregnant equally as if you were treating them. And the other important observation here was that after 1 year, when a repeat DNA PCR test was done, the patients who had been treated also continued to remain positive in large numbers. So which means that even if the treatment was done, the bacteria were dead, the PCR test continued to come positive. And so the study really said that do not use antituberculous therapy just on the basis of a positive DNA PCR. You may end up really over-treating patients, and don't keep on giving antituberculous therapy till the PCR becomes negative, because that may take a very long time to happen. And so that was an interesting study and gave us quite a good message. So because of all these challenges, it becomes really difficult to treat this group of patients. And very, very often it seems that IVF is the only hope, because, the tubes are blocked completely. So at least if the endometrium is good, then IVF will give us a reasonable pregnancy rate. Average pregnancy rate is 17%. It is lesser than that of a patient who's coming for infertility for some other reason. And the reason even IVF success rates are a little low is because of poor endometrium, poor endometrial blood flow, and the possible damage to the ovaries, which causes low ovarian reserve in these patients. And so these are the issues we encounter. Like very often nowadays, we are seeing younger girls with a very low AMH, with very poor ovarian reserve, and we start suspecting that maybe they have been exposed to genital tuberculosis, if no other obvious reason is there. And so, again, a nice Indian study where women with latent tuberculosis, female genital tuberculosis, had low AMH, low antral follicle count, and when you actually gave them therapy, they were, they did yield oocytes, and pregnancy rates were fairly good. So latent genital tuberculosis may be not that significant. They may have lesser oocytes, but eventually pregnancy outcomes are sort of similar, though it may take longer. So Dr. Sharma's study is also a little bit positive, or is encouraging that when you treat women who have tuberculosis of the genitals, but the tumor masses are not there. When you treat these women, you actually can see a significant improvement in their ovarian reserve. The AMH increases, there may be an increase in the antral follicle count. So the important thing is, if we diagnose early, we treat them, then there is actually an improvement in the ovarian reserve parameters, and the egg number and quality may be slightly better. The blood flow to the ovaries is improved. So early diagnosis and treatment remains important. What about the effect on the endometrium? We all know that endometrial thickness is an important component when we are doing even IUI or when we are doing IVF for all patients for infertility treatment. And very often we see that the endometrium in these patients is thin, it's avascular, we don't see the typical triple line pattern, and that's why women who have endometrial damage with TB, the results are very, very poor. And so we have shown poor result in most patients with female genital tuberculosis, because they're poor responders, they need a high dose of gonadotropin. Endometrium, like I mentioned, may be poor, it may have poor receptivity, even if they look reasonably okay, and the oocyte and embryo quality may be poor. And so though sometimes it's the only option that we have if the tubes are blocked, the outcomes in IVF are inferior in badly damaged tubes, ovaries, and endometrium. So I guess we have to, in most cases, follow the guidelines for poor responders which we follow. For any other poor responder, very often for tuberculosis patients, we need that. And with all of this, the IVF success rates, we've seen many studies. Some of these are fairly older studies, but the results are very, very variable. Pregnancy rate could be as high as 35, 38% in some patients, in some studies, and as low as you can see as 9% in certain studies. So pregnancy rates are very variable. I guess depends on the extent of damage, endometrium involvement, and the ovarian reserve of the patient. And some studies which are a little bit more recent, and this is one of them, 2020 study, where 155 women with genital tuberculosis were studied. And it was found that if you have tubal tuberculosis, the results are fairly good. But if you have endometrial tuberculosis, then implantation is very, very poor, and the pregnancy outcomes are very poor. So not only do you diagnose the patient with female genital tuberculosis, distinguish between the two, whether endometrium is affected or whether only tubes are affected, and give them a prognosis accordingly. So we know that, there is very sort of a dismal sort of outlook at this stage. But typically, when the world says give up, it is hope which tells us that we should try one more time. And so we have to do everything that we have in our armamentarium for this group of patients. Whatever we can try to, for example, improve ovarian reserve, we should try. And there are systems and methods in place which are being tried for ovarian reserve improvement. None of these are proven or they are very highly recommended, but these are certain trials that are going on where we see if PRP is injected or stem cells, augment technique in certain cases to try to rejuvenate, in vitro rejuvenation of the ovaries. These are being tried. So not very, very, very encouraging, but definitely something we can look at as a possible option. So intra-ovarian PRP, I think, is one of the most explored one of these tests, of these therapies. From the last few years, many, many cases have been done where platelet-rich plasma is freshly isolated from the patients, and immediately it is activated with calcium gluconate, or now you get ready-made material into which the blood is collected. Freshly prepared PRP is then injected into the ovaries, either under ultrasound control, which I find very difficult, or with laparoscopy. And early studies found a good improvement in the AMH and the egg number and the possibility of pregnancy. And all of us now have some experience with it, and it does appear to be fairly optimistic, the results. Not only PRP, even stem cells have been tried. So autologous stem cell ovarian transplant is being tried. Ovarian infusion of bone marrow-derived stem cells is being done. And again, studies have been encouraging that ovarian function improved in 80% of women, is what this study in fertility, sterility has shown. So there are possible ways by which these stem cells may work. They actually improve follicle and oocyte quality. So that is something else which can be tried. In vitro activation, much more complicated, where you actually remove a piece of the ovary, cut it into strips and freeze it. And then whenever you need to transplant it back, you actually bring it out, thaw it, cut it into pieces to activate or disrupt the hyposignaling pathway, incubate it in AKT stimulators for 24 hours or so, and then wash them and put it back in the ovarian fossa. And you can actually see patients who have spontaneously ovulated and even become pregnant spontaneously or with IVF. So these are some studies which have said positively about in vitro activation. But because it's a difficult procedure, involves 2 laparoscopies, I think most people are not very happy to do this procedure. It is said that there are stem cells in the ovaries which can be extracted and which you can actually grow to form new eggs. But again, this is very early days for ovarian stem cells. Also, more and more now, we are able to grow cells from very immature ovarian cells from a very immature state to full maturity in a lab. And these studies have been published. Again, like I said, early days, of being able to pick up very, very immature human eggs and growing them to full maturity. So these are things which will be the future, where patient doesn't have a growing follicle. You can pick up the immature eggs and grow them in the lab, and maybe futuristically even an artificial ovary in a patient in which the ovary is very badly damaged. Typically, these are being done for cancer patients, but according to me, tuberculosis can also cause as much damage as can a malignancy treated with radiation or chemotherapy. So we can actually have a scaffolding of an artificial ovary and implant eggs into it and put it back into the patient. So maybe in the future. So these are all very futuristic researches that are going on, and we hope that these will help us. But again, coming to the last part, that is the endometrium, because very often ovary, in fact, less damage with tuberculosis. Endometrium, very often we find that it is damaged with endometrium, and it's very difficult to treat a non-responsive, refractory thin endometrium. You can try hysteroscopic adhesiolysis, give a lot of estrogen to the patient, give aspirin, vitamin E, give arginine, give sildenafil. Many times, all of this combinations are also used, but the results are not very, very encouraging. And so sildenafil seems to be a little bit helpful. You give vaginal sildenafil, there may be an improvement in blood flow and endometrial thickness, but it is not a magical solution. We are now trying quite often the granulocyte colony stimulating factor infusion for these patients. You can even give it subcutaneously. And again, it is shown to improve endometrial receptivity, thickness to a small extent, but it may improve pregnancy outcomes. And it is actually approved by the US FDA for patients with recurrent miscarriage or immunological causes of infertility. So a small amount of intrauterine infusion of GCSF, and there may be an improvement in the receptivity. Similarly, platelet-rich plasma. So patient's own blood is collected, it is prepared, and PRP is prepared, and we can do an intrauterine infusion of this PRP. Some people like to inject it subendometrially, and this can be helpful in improving endometrial thickness, receptivity, blood flow, etc. So platelet-rich plasma is another thing which can be tried. And you can actually do a combination of the two things. You can give PRP 0.7 ml or so intrauterine injection, and you can give GCSF 500 milligrams or 0.5 ml subcutaneously. And you start it simultaneously with the PRP and continue it every week. So this combination, GCSF subcut and PRP intrauterine infusion about 48 hours before ET, may help in some patients again. So these are things which are being tried because it's a very desperate situation where a very poor endometrium is there. Again, stem cells, like I said, have been tried with some success, and basically the endometrial mesenchymal stem cells have been injected either into the subendometrial space or have been injected into the uterine artery as well. And there seems to be some benefit with these stem cells. Eventually, of course, if all these semi-experimental techniques fail, you have to resort to surrogacy, because if there are massive intrauterine adhesions, atrophy of the basal layer, endometrium persistently very thin, unexplained repeated IVF failures, or if there's a drug-resistant genital tuberculosis, then you have to resort to surrogacy. And like I said, usually the eggs are a little better, ovary is not that damaged. You do surrogacy, you get very good outcomes. And of course, if the ovaries, tubes, everything is badly damaged, or even the husband has a male factor, you can obviously go for adoption. So always we have some options available to us. But remember that when we are doing IVF for these patients, especially if they have some form of active tuberculosis, which you have missed, have not picked up or not treated fully, then you can have issues such as biliary tuberculosis rarely coming up, activation of the pelvic tuberculosis, abscess in the ovary, and there have been reports of congenital tuberculosis in the baby. It's very rare nowadays, and you can treat the babies immediately. But this long-term study showed that even now, you do have babies being born with tuberculosis. So really, when faced with the challenge, we have to find a way, not a way out. And we hope that in the future, we'll be able to diagnose tuberculosis very early. That is really the challenge. Diagnosing and treating latent tuberculosis is a really important strategy to accelerate the decline in global tuberculosis and achieve TB elimination, which is one of our goals of the future. And it's really, really difficult to diagnose. Difficult patients don't take treatment properly, and which is some of the major barriers that we face. But we hope that with these new assays, with the interferon gamma release assays, with the early diagnosis, we'll be able to treat these patients better. So the challenge is to diagnose early and to treat fully. And new things are coming up. Like just one example is this fibroblast growth factor 2, basic fibroblast growth factor, which has been used all these years for burns, this to inject it around burns to grow tissue. And this is now actually being injected 100 micrograms of this around the scarred endometrium by ultrasound guidance every 4 weeks. And it was found that, the endometrium around the scarring grew better, patients' menstrual volume increased, endometrial thickness increased, and some of these very dismal patients could actually achieve a pregnancy. So that could be a possible therapeutic option in the future. So lots to look forward in the future, because we know that the endometrial biome, the bacterial communities in the uterus, in the cervix, vagina, are extremely important for fertility, and good studies on these will be impactful. A regenerative medicine with stem cells, that may be a solution to many of our problems. Regenerate the endometrium, regenerate ovarian tissue, and we'll get benefits. And of course, maybe a possibility of even artificial bioengineered uterus being created in patients in whom the endometrium is completely irreversibly damaged. So we have a lot to look forward to in the future. Even uterine transplant is something which has become a reality now. Many cases have been successfully transplanted, the uterus, and even babies have been born. So all of these are available to us. Not only uterine transplant, ovarian transplant is in fact very successfully being done, whether it is an auto transplant from cryopreserved tissue or an allo transplant from HLA matched donor. And you'll be surprised to know that most of these patients did extremely well. They had not only ovarian and endocrine function restoration, but also the follicular growth. And 50% plus patients reported pregnancy after ovarian transplant. So all these are there: ovarian transplant, uterine transplant, stem cell therapy, lots to look forward to in the future. So the end message really is that let's not give up. Whatever we face, let's fight it, let's work around it, let's find solutions to this extremely difficult problem of female genital tuberculosis. Thank you.
Sonia, your comment first.
Well, thank you, Reshma. Thank you for this very exhaustive. I would say from the beginning to the end of tuberculosis, you have covered everything. You have started beautifully by telling us how difficult it is to diagnose the condition. And then, of course, the problems that we face while treating this condition as well. And then what are the possibilities that are there for us in future? So it is a kind of a summation of what is happening to the world of tuberculosis, genital tuberculosis, I would say, and how we are and where we are presently at it. The only little bit that I would like to add to this is that we all must always remember that tuberculosis has now become a notifiable disease, which we mustn't forget. So even when we diagnose female genital tuberculosis, we have to report it. And that system has been very well placed, put in place by the government now. The second thing that has happened is that the ICMR brought out guidelines about tuberculosis about 2 years ago. Unfortunately, they did not become popular because it happened during COVID. So many of us did not know about it, but they have actually defined tuberculosis in various ways, in the sense that, okay, if this is present, this is definite tuberculosis. If such and such thing is present, it is probable tuberculosis. If you find such history, then it is a resurgence of tuberculosis. So a kind of a definition is in place. And depending upon what tests to be do, they have actually defined how to go about treating it. So that document is available on the net. And I think every one of us who are dealing with female genital tuberculosis should know of this document, and they should incorporate it in their private practice, so that, it becomes easier for all of us now to go about it. You have summed it up very well, but to have it in that algorithm kind of a thing, we need to look at this ICMR guideline, which has come out. And that's it. That's all that I have to say. And about the future of treatment of tuberculosis, again, a word of caution. Since we are not sure which PCR or which test is indicating an active tuberculosis and which one is actually indicating a latent tuberculosis, putting in PRP or stem cells into an ovary where we are not sure of inflammation is something which is to be, there has to be caution. Because if we put in anything like a stem cell into an ovary which has active inflammation, then it may go the wrong way. And therefore, we may do more harm to the patient rather than that. And that is something, I'm saying this to the viewers. When Reshma does it, she's going to be very careful, and she will see that she is not going to instill it in a patient who is she's kind of suspecting tuberculosis. But when everybody starts doing it, they forget it. And they just say, oh, PRP, that is the end all of everything. Please don't do that, because you may inject it into a person who's already having active tuberculosis, and then you've had it. And then even the endometrium will be finished. It will be destroyed if you're going to put PRP in that, even GCSF for that matter. So whenever you are suspecting inflammation, please remember, do not do it when there is active inflammation. So these are my few observations and points. Reshma, your comments on this.
Thank you for bringing that up. I did mention that with the flare-up of tubo-ovarian abscesses, etc., even if you do an IVF or an ovum pickup,
yes, absolutely,
unknowingly, and there have been reported cases of abscesses, and it doesn't apply only to tuberculosis. Any pelvic infection, you don't want to go in and do any active treatment or intervention in that situation. So we have to be very careful. Problem arises that it's difficult to diagnose sometimes, and that is where unknowingly you may put your finger into it and then get into a bit of trouble. So yeah, so as long as we get good diagnostic methods, I think a lot of problems will be solved. But till that time, it's going to be difficult, definitely.
And of course, a sole PCR positive is not a diagnosis of tuberculosis. That
already a study has come.
Absolutely, absolutely. Everybody has to understand that there has to be an additional symptom or a sign or a history suggestive of tuberculosis. Only then can you say that this patient has tuberculosis, not just PCR positive. That's for sure. Doctor.
Thank you, Reshma. You did an excellent job, as usual.
Very
From
good.
very dark zone to you brought us to a greener zone, where things are possible even in a very, when wall is there, you can just jump over it, whatever you suggest. You rightly mentioned about few things that diagnosis, as Sonia has mentioned, is very difficult. So stick to diagnosis first, then try to go ahead with other treatment part. Very difficult treatments are still not available in our country, may not be available for a few more years. So cost effectiveness also is important. And when other things you are discussing, you think about that part also. And patients, because most of our patients are not able to afford it all, because that has not been government subsidized as far as infertility treatment is concerned.
One very beautiful thing. Yes, sir.
One more thing. See, do you suggest about tubes are involved and you want to do for IVF, whether you move to tumor of tube as we do it in hydrosalpinx? Is it necessary in all the cases?
Definitely.
For IVF.
Yeah, if a hydrosalpinx is visible on ultrasound, the standard guideline is that it should be removed. So if it's so small that you pick it up on a laparoscopy and it's not even visible on ultrasound, you can leave it alone. But typically, the results are better if a visible hydrosalpinx is removed or clipped or salpingectomy done or something like that, yes.
Anju, you want to say something?
Yeah, I just want to stress upon one thing which Dr. Reshma has said in the beginning. Whenever we are doing a laparoscopy or hysteroscopy, maybe not for tuberculosis per se, an infertility patient. So the moment you put in a hysteroscope, just give some time to your eyes to look at all the walls of the uterus and see you can see those tubercles. If you see your cavity very carefully, that is quite diagnostic. That is very important thing, because people just put in and look for the tubes, and they don't give time to visualize the cavity. That is one very important thing which you said, which I want to reiterate and re-stress on. And secondly, when you put in a scope in for doing a laparoscopy for per se any infertility or a pain abdomen or anything, you meanwhile, when your table is being put head down, you should always rotate your camera and look under the diaphragm, under the liver. This is so very much important, because in so many of cases, you do not have any other symptoms or signs per se, but that becomes the diagnostic part. So it is very important that whenever you are putting in a scope, please go upwards, see under the liver and diaphragm, and you can catch those patients, because you pointed out it earlier, and it is so very important for practical reasons. So I just wanted to re-emphasize the whole thing.
Thank you.
Pratik, you want to say something?
I think, as usual, it was a masterly performance from Dr. Reshma Pai. We were all spellbound and enthralled. Thank you very much for bringing the length and breadth of the diagnostic armamentarium and the future technologies which will make a difference to these patients over the years to come. Thank you so much for a beautiful presentation. Awesome to listen to.
Thank you.
Thank you very much, Dr. Reshma, for giving this beautiful topic to us and covering up each and everything so well, even showing the future. We all know that tuberculosis is so very much common in our country. And if we can diagnose them early, and maybe then we can help these women so well. So thank you very much. And a gentle request to all the viewers who are watching that I'm going for Vice President West Zone this year, 2024. So looking forward to your support. Thank you very much.
Thank you.
Thank you. Thank you. Nice meeting you all.
Thank you.
God bless you soon. Bye, Reshma. Wonderful.
Bye-bye. Take care.
Bye.
Bye. Thank you, Reshmi. You were really good. तूने बहुत
Thank
अच्छा
you,
करा
ma'am.
बेटा.
Thank you for the opportunity, ma'am.
Thank you so much. Thank you so much.